Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Nathan Pennell, a medical oncologist and director of the Cleveland Clinic Lung Cancer Medical Oncology Program, and Dr. Laura Tafe, a molecular pathologist and associate professor at Dartmouth Hitchcock Medical Center in New Hampshire. They will be discussing testing for actionable biomarkers and leveraging targeted agents in non-small cell lung cancer. This episode is part of a larger educational program titled New and Evolving Therapeutic Targets in Lung Cancer, Expert Guidance in Incorporating Biomarker Testing to Deliver Precision Therapy. For more information on Dr. Pennell and Dr. Tafe, along with a link to the complete program, including downloadable slide sets and on-demand webcasts, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
We're going to try to answer just a few audience questions. And most of these look like pathology questions. I guess.
While I look through those, Dr. Pennell, can I ask you a quick question? So I suspect many people on the call might be from pathology and lab medicine, and we know how important the turnaround time is. But can you tell us a little bit about what happens next in the patient's care after you get these results of my patient has a biomarker in their tumor that I can treat? What happens next? Because that's often the part that we don't hear much about from the laboratory perspective.
Well, actually, usually I have it sort of circled on my Outlook calendar when I expect the testing to come back. And sometimes for these commercial vendors, you get an email or a text on your phone that the results are ready. So I could get it like at my dinner table at 9 o'clock or something, that there's something there. And so if I were to see like an EGFR mutation or a MET exon 14, I oftentimes just call the patient right away because we have to do prescriptions through specialty pharmacies, which often take a few days to a week to get insurance clearance. I basically tell them the good news. Oftentimes we've already preliminarily set up chemotherapy and immunotherapy to start while we were waiting, and then just say, well, we'll cancel it if we need to. So we cancel their treatment, we prescribe the medicine, we do teaching over the phone, and then we wait for them to get their drugs shipped to them. So it's actually really exciting.
How long does it usually take for that approval?
It depends a lot on the insurance. If they need to apply for copay assistance or free drug from the company, it can take much longer than if their insurance just has coverage and they can afford the copay, in which case sometimes it can be as little as a day.
Okay. All right.
But it can be as long as a week or more sometimes. And sometimes that's very relevant for how sick these patients are.
Yeah, absolutely. Okay. All right. Shall I try to answer a few of these?
Sure. I think, there's a couple that sounded really important to me. Like one
okay, go for it.
That I thought was very relevant was the difference between cytology versus pathology, because most of the assays seem to be validated on surgical pathology or anatomic path specimens, but lots of patients have cytology or cell blocks. And so what's the relevance of those in terms of doing biomarkers?
I would say that probably in my laboratory, in my experience, the best for lung cancer patients, the majority of our specimens are the small biopsies, cytologies, FNAs, that we're actually doing the biomarker testing on. So like in our practice, we don't wait until we get the excision. We will do the testing on the initial diagnostic biopsy specimen. And part of our assay validation includes these specimens. So we have included cytology, FNAs, core biopsies, and so on as part of our validation of our NGS panel. So we know that it's in good hands with us and that we have experience with these as one of our key clinical specimens. And that's why these are so important to handle correctly in terms of optimizing conservation of that tissue.
Yeah, that's been my experience as well, is that the cytology is just as good. And we actually, extract DNA directly from like liquid cytology specimens and everything. We've been doing this for years and it works quite well.
Yes.
So let's see, here's a question that I can answer. Why is the turnaround time for liquid biopsies shorter than tissue? And I think that that's a tissue handling issue. I don't think the assay actually takes any shorter or longer. I think it's a matter of you can draw the blood and then they can extract the DNA directly from the white cells. It takes longer to do the processing for the tissue, does that sound right?
I think perhaps my laboratory is not performing liquid biopsies in-house, so liquid biopsy in my institution goes to a different lab than the solid tumor testing, because we do most of the solid tumors in-house. So, or I should say the paraffin tissues in-house. But I think, yes, that's theoretically a possibility. Also for just part of the ordering too, I think there's a step between when the specimen might be ordered for testing for the FFPE tissue. That tissue has to be retrieved from archives potentially, and then cut and circled and extracted and so on. So yes, it probably is a tissue handling thing too.
So one question is a treatment question that I can probably try to answer. Would you use the Keynote 189 regimen, which is of course platinum, pemetrexed, and pembrolizumab in patients with RET fusions, BRAF mutations, or MET exon 14, which is a great question. So would you use it first line? So we don't know how effective Keynote 189 regimen is in any of these patients because they didn't test for any of those. They did exclude patients with EGFR and ALK, however, so we don't have data from that either. We do know that immune checkpoint inhibitors as single agents tend not to be as effective in many of these patients, definitely EGFR, ALK, ROS1. That's probably also true for RET. I do think retrospectively that the response rates in things like BRAF mutants or MET do seem to be higher than in other driver oncogenes. I guess the short answer though is, given the highly effective nature of the drugs and the relatively lower toxicity, I would not. So I would definitely use, say, selpercatinib or pralsetinib for a RET fusion positive, dabrafenib, trametinib for BRAF, and capmatinib for MET exon 14, preferentially instead of chemo plus immunotherapy, because we don't just have the data to know how well the addition of immunotherapy would be to chemotherapy. And I think the targeted drugs are much more effective than chemo, at least in those populations. One question that was earlier for Dr. Tafe, what is the difference or what's the concordance between IHC and FISH or NGS for ALK?
They're actually very high. I don't recall the exact number off the top of my head right now, but in the high 80s, mid 90s for the ALK, IHC, and FISH. There are a number of papers that have looked at that. Neither of them is quite perfect, and they might have some discrepancies, but the concordance is very high and acceptable. And I also did see a question about that I also wanted to address. Sorry, I lost it right now. About the use of cytology fluids for testing for MET, RET, NTRK, or MET amplification. And I'm thinking this is a question about FISH analysis. And yes, fluid cytology specimens are appropriate. They can be used for FISH analysis, if that was the question. They can also be used for NGS analysis. Cell blocks can be used for FISH analysis, and also so can the fluid fixed on on the slide too. So you can have a smear or preparation that we can also perform analysis on.
Here's a question. NGS is obviously expensive. Would you recommend doing something like FISH prior to doing NGS? And that sort of brings in the whole question of sequencing. Would it be better to do a cheaper screening test to look for some markers before going to broader testing? That is probably most commonly mentioned, thinking about doing something like either EGFR or even KRAS mutation testing up front, because they're the most common and can be done quickly with some of these PCR-based assays. I know that there are centers that are doing that as sort of quick they're not necessarily waiting to send that, but they're doing that to get the answers faster. I will say that there have been some publications, including from my group, looking at cost. And if you think about it this way, yes, NGS is more expensive, but if hypothetically NGS costs $300 and a single gene test like EGFR costs $100, by the time you got to 4 single gene tests, it costs more than doing the NGS, which can then actually test for hundreds of things and not just 4. So the turnaround time, or the cutoff, seems to be once you're doing more than 3, once you get to like 4 single gene assays, it's cheaper to do a multiplex test than it is to do a single gene.
Yeah, I absolutely support that and agree, particularly with so many markers that we need to test for now. A few years ago, we were able to do an ELK and a ROS1 FISH and an NGS, but now, or DNA-based NGS, I would say, not looking for the fusions, but now we have to test for so many things that going straight to an NGS panel really makes a lot of sense in terms of that cost analysis too, because IHCs and FISH assays are much more expensive than you would initially think they
are. Do we see RET fusions in early stage non-small cell? Well, I think we probably will see all of the targets in all stages of lung cancer. The issue is, of course, they're not typically looking for it. But I think that may be changing now that we have data from the ADORA trial suggesting that there may be good clinical benefit to using adjuvant osimertinib for EGFR mutant non-small cell in earlier stages. Probably doesn't make a whole lot of sense to do single gene testing on those patients either. We might be doing broad testing as well, in which case we'll start identifying all of these in the early stage. The question then, of course, will be, do we have enough data to support treating earlier stage patients with these targeted treatments? And while I have an opinion about that, that is definitely the material for another CME talk in the future.
I see one more question I'd like to address real quick. The comment was that this particular individual's pathology group does not allow their pathologist to order reflex molecular testing panels for lung cancers. And so when I said that we did here, the question was raised, what do we order and when? And so this is our reflexive in-house testing is something that we established many years ago with our clinical colleagues. So we met with our oncologists and kind of devised a workflow and a plan to do this reflexive testing. And it involves a diagnosis, and any new diagnosis of lung cancer. We really don't depend on the stage specifically. And that can be a cytology diagnosis or more of a biopsy or ultimately an excision. When we are making the diagnosis of non-small cell non-squamous, as a pathologist, we order a panel of molecular tests as well as the PD-L1. And so in our assay, that in our institution, that is the NGS assay, which is a combined DNA and RNA based analysis. So that's a workflow that we've established internally within our institution. And so I think setting up those types of procedures, it's really imperative to have buy-in from your oncologists, from your interventionalists who are performing the biopsies, from your cytologists who are doing the Rose assessments and helping to triage that tissue. So that really is a system approach that has to be implemented in order to do that.
Thank you very much, Dr. Pennell and Dr. Tafe, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, New and Evolving Therapeutic Targets in Lung Cancer, expert guidance in incorporating biomarker testing to deliver precision therapy, and to download a podcast Pearls PDF summarizing key points from this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.